Hi, and welcome to NUR PNR 180. We're going to be talking about the concept of gas exchange for the pediatric patient. In particular, for this class, we're going to be talking about respiratory syncytial virus, abbreviated RSV, also asthma, and cystic fibrosis. So it is important to remember that in children there are differences with the respiratory system. The respiratory rate is typically higher in children. The tracheal diameter is also smaller in children. The work of respirations in infants is typically abdominal. And there is a resistance, and it's related to the radius of the airway. It's much smaller. Something that is of interest is that a newborn will have about 20 million alveoli, where an adult will have more than 300 million, alveoli in their lungs. So that's just to kind of identify the differences in pediatrics as compared to the adult. The first disease that we're going to talk about is RSV. It is an acute viral infection. It is the most common cause of a condition called bronchiolitis in children under the age of 2. Although older children and adults can also get RSV, we typically see it causing a more severe infection in those under the age of 2. What happens in RSV? There is an infected mucous membranes, and they become filled with exudate, and this is typically seasonal in its incidence, where the viral infection, essentially you'll see it, 80% of the cases will begin in late fall. They reach a peak during the winter, and then you'll start to see a decrease in the spring. Individuals at risk, we see those with low birth weight, those who have bronchopulmonary dysplasia, those with neuromuscular disease, those with a family history of asthma, those individuals or children who are exposed to secondary smoke, and those who go to daycare, and those children who are chronically ill are more at risk. So people who have other types of conditions going along with contracting this infection. So what's a pathophysiology? When we look at pathophysiology for someone who gets RSV or bronchiolitis related to RSV, the bronchial mucosa basically swell, and the lumina fill with mucus and exudate. And as you can tell just by that explanation, you're seeing that the airway is becoming narrower and it's becoming filled with exudate, so making it difficult for breathing. The walls of the bronchi and the bronchioles become infiltrated with inflammatory cells, so further decreasing the ability for gas exchange to take place. Also, there's varying degrees of obstruction, which are produced in small air passages, which lead to hyperinflation. There's also narrowing of the passage on expiration, which prevents air from leaving lungs, resulting in air trapping. So with someone with this particular condition, you'd see them more in a respiratory acidosis. They're retaining CO2. What are some of the initial symptoms? It includes rhinorrhea, which is a runny nose, essentially, pharyngitis, coughing, sneezing, wheezing, and they will typically present with a fever. As the illness progresses, you'll see increased coughing and wheezing, air hunger, tachypnea, retractions, and eventually cyanosis. So severe illness, they'll have a tachypnea greater than 70 breaths per minute. You'll start to see them listless, and they will have apneic episodes. Obviously, they're having poor gas exchange or air exchange and poor breath sounds. So that is obviously, they're quite serious at that point. The diagnosis is made after positive nasopharyngeal swab. So you know how we do those nasal swabs for COVID, and sometimes they'll do pharyngeal swabs. Well, they will also do that. It was not the first time that we've done testing for certain viruses. They do that to test for RSV as well. Chest x-rays will illustrate air trapping. WBCs will be elevated. Their ABGs, arterial blood gases, may be abnormal, and their SpO2 or their oxygen saturation obviously will be decreased if they're not having proper gas exchange. What do you think? Like I just mentioned in the past slide, what do you think that their ABGs might reveal in their pH? They're going to see an acidity in that because they have increased carbon dioxide. So their O2 sats will typically be less than 90. So you will see very symptomatic, these patients. How do we manage? Well, there are different varying degrees of RSV and of bronchiolitis. And if it's a minor case, it's managed at home and it's usually symptomatic. The treatments typically will include high humidity, adequate fluids, rest, antipyretics such as Tylenol, and if it becomes more severe and they're hospitalized, they may give antivirals, and we'll talk specifically of what antiviral they often use in someone who has severe RSV infections. They will sometimes use corticosteroids. That's a little more controversial in helping someone with the RSV. However, it's not completely ruled out. So as the RSV progresses, you're going to see the child being tachypnic. They have marked retractions. Again, they experience what's called listlessness. They have a history of poor PO intake, so they're not taking in, if they're nursing, they're not taking in the mother's milk, or they're not taking in formula, or they're not able to eat because they're having such a difficult time breathing. The treatment, again, involves mist therapy combined with oxygen in concentrations sufficient to alleviate dyspnea and hypoxia. And if you went into the hospital and you saw someone who had RSV and they were hospitalized, typically they're under a mist tent, and you would be able to see that if we had the experience on an acute care setting for this semester. But we do not. We have it more in a chronic. And we are more apt to be in the schools, where we will see children being infected also with RSV. After which the mist will be continued for mild dyspnea. Healthcare providers should use contact precautions when caring for patients who have RSV. They might give a medication such as ribavirin. That's a broad spectrum antiviral. It's used for severe cases of RSV. Or for patients with significant underlying risk factors, those who might have had transplants, those who have suppressed immune systems, things like that. There are concerns about potential toxicity. They have linked this particular medication, or there is thought to be linked to some type of teratogenic effects on a fetus from the aerosol use of it, so that it is advised that pregnant women do not take care of a child who's receiving ribavirin. This has not been proven. However, most hospitals will abide by not assigning a pregnant woman to take care of a child who is receiving ribavirin in case there are teratogenic effects on that. And typically when you have someone a healthcare provider who's caring for someone with RSV, we try to keep those patients in the same cohort and try to keep the nurse taking care of the same group, and they won't be taking care of someone who has a different illness, where they might be prone to contracting RSV. So we also use prophylaxis such as RSV immunoglobulin or monoclonal antibodies. It's basically to prevent RSV, and it's basically the antibodies that they're giving to children who are at high risk during the RSV season. That would be preemies or those with chronic lung disease, like cystic fibrosis or things like that, which we're going to be talking to later. The recommended dose for someone receiving the RSV immunoglobulin or IVIG is about 15 milligrams per kilogram IM monthly. The first dose is given before the RSV season, and then it's continued throughout the RSV season. Even if the child is infected with RSV, they will continue to give this prophylactically, giving them the antibodies. One particular brand is Synagis, or another one, Palivizumab, and they will give that regardless. The cost, it's costly, but it's something that's still used quite a bit on children and preemies and people who are at high risk. So family teaching. Hand washing, obviously, before handing an infant. Keep people with colds away from the infants. Stay away from crowds. Check that the daycare does not expose an infant to crowded conditions and that they clean the toys and disinfect things and wash their hands and they're properly trained. Wash babies' toys and bedding often, and do not expose infants to smoke because that makes their breathing that much more difficult. Nursing diagnosis with someone with RSV. Ineffective airway clearance related to increased secretions, ineffective breathing pattern related to inflamed tracheobronchial tree, risk for fluid volume deficit related to inability to meet required requirements secondary to respiratory distress, and fear related for the need for hospitalization. Obviously, that is the parents are more fearful, or if the child might have fear if they're a little bit older. Also, knowledge deficit related to diagnosis and treatment, risk for transmission of infection, and altered growth and development may apply if the patient has chronic illness as well. So some nursing interventions. You're going to place them in a private room typically, or in a cohort room, which I had mentioned previously when I was talking on the other slide, that we want those children to be separated from other children who are sick in the hospital. We want them, if we are going to have them with another patient, that they also have RSV. We're going to suction as needed, maintain humidity, and provide O2 to keep this O2 sats above 90. They're going to feed, and then when they feed them, it will be small, frequent amounts so that they can handle it, so they're not trying to take so much in and they have a difficult time breathing. And also we are going to manage their hydration with IV fluids. And of course, we know that elevating the head helps to decrease some of the pressure on the intercostal muscles and on the diaphragm, and that helps to open up airways, so we keep the head elevated at all times. You do not assign the same nurse to the patient, as I mentioned in the previous slide, with RSV to another high-risk diagnosis, and you want to teach family members how to avoid transmission, hand washing, maybe mask wearing, things like that. And what we expected of these children who suffer from RSV, we want a complete resolution, and that is expected, and that is our goal. So the next thing we're going to talk about is asthma. Asthma is something that we see quite frequently in children, and I'm sure that you've all seen them with children in the schools, and that's probably one of your number one visits. Asthma is a chronic inflammatory disease of the airways, and it's the most common chronic illness. It is the most common cause of missed school days and hospitalization. It also reduces the productivity of parents of children with asthma. So those parents have to take time off work, and they have to be home to take care of those children, so their productivity is also affected. Let's see, next. So what happens in someone with asthma? So usually there is a bronchospasm and obstruction. Those are the key components of what occurs with asthma. The mechanism responsible for the bronchospasm and obstructive symptoms include inflammation and edema of the mucous membranes, accumulation of thick secretions from mucus glands, and spasms of smooth muscle, which decreases the size of the bronchioles. There is also an increased resistance in the airway, causing forced expiration through a narrow lumen. The air gets trapped in the lungs, causing the asthmatic to breathe at higher volumes. The asthmatic fights to inspire air, causing fatigue and decreased respiratory effectiveness. And as this process continues, there's a reduced alveolar ventilation with CO2 retention, which leads to hypoxemia and eventual respiratory failure. So if you look at this particular example, over here on the left-hand side is a normal airway that is not affected by asthma. You can see that it's nice and clear, and the walls are normal size, they're not swollen. And then you see someone who's suffering from an asthma attack. You see the swelling and inflammation here, causing to constrict the airway, and also you see exudate or mucus being formed. So obviously this person's going to have a much more difficult time passing air through their bronchioles and bronchi than someone who does not have asthma. So what are the clinical manifestations of someone with asthma? Cough, hacking, irritative. At first it's non-productive, And then as the symptoms continue, the cough becomes productive and they're able to get some of that excudate out. They'll have shortness of breath, prolonged expiratory phase, audible wheezes. You might hear it with or without a stethoscope. As the person suffers more asthma attacks, you might see that they have like a malar flush and red ears, dark lips, cyanosis of the nail beds, restlessness, apprehension, and panting. And they also will have coarse, loud breath sounds, wheezes throughout the lung fills, and crackles. So if you have someone who comes to the school and is in an asthma attack, you might even hear the audible wheezes without using your stethoscope. But you should be able to listen to sometimes these children and listen to their lung sounds and see if they are having an asthma attack and what type of lung sounds you're hearing, and if they are tachypneic, and you want to make all that assessment when the child comes in complaining of that. Some other clinical manifestations that you see, those children with asthma tend to get barrel-chested. They'll have their shoulders elevated. They'll use of accessory muscles for respiration. After a period of time, the facial appearance, you'll see more flattened malar bones, circles beneath the eyes, narrow nose, and prominent upper teeth. So asthma has a classification system. So we have 4 steps. So the first step, or step 1, is intermittent asthma. The second step is mild persistent asthma. Step 3 is moderate persistent asthma. And step 4 is severe persistent asthma. The goal of asthma management is to obtain a symptom-free life without any abnormal lung function. So that is our goal, and hopefully that will be something that we're able to obtain with most of our patients. So let's look at these. So the severity, intermittent, that is about 1 to 3 exacerbations of the past 12 months. The symptoms are less than 1 time a week, or equal to. Waking at night are less than 2 times a month, and there's no limitations in activities. So mild to persistent is about 4 to 12 exacerbations over the past 12 months. Symptoms are there's several times a week, no more than 1 attack per day. They do wake at night, but it's greater than or equal to 2 times a month, and sometimes affects activities of daily living. The moderate persistent is greater than 12 exacerbations over the past 12 months. They have daily symptoms with occasional improvement. They're waking at night 1 to 2 times a week, and it sometimes affects activities of daily living. Severe persistent is greater than 12 exacerbations over the past 12 months, continuous symptoms, daily or no improvement, waking at night, greater than 2 times a week, and always affects activities of daily living. So what are the characteristics of interest? So there is a genetic risk factor. Those who have family members who have asthma, you seem to see it run in families. So children with asthma are more likely to have a parent, especially a mother with asthma. Adult women are more likely to have asthma, suffer asthma more than adult men. And there is an RSV connection, which is kind of interesting. Also, there's racial disparities. African Americans and American Indians have a higher prevalent rate than Hispanics and Caucasians. But yet, just interestingly, Puerto Ricans have a highest rate among the Hispanic groups. And emergency admissions for African Americans were 3 times greater than those for Caucasians. The age and incidence, typically we will see youngest children will have the most admissions to emergency rooms, more so than older children. And poverty is actually a big factor in those having asthma. We see people more who are in the lower income suffering from asthma more frequently than those who are of an average or upper income. So, what are the family teaching needs? So we need to teach the family and the patients what is the trigger? What is a known trigger for this particular person that would cause an attack? The patients also should know how to use the medications properly. There also may or may not be a plan in place for the patient who has increased symptoms. And also, we need to let them know that the cost of the medicine can be quite expensive, and if there's alternatives to help them pay for some of the medications. So when you're at the schools, you want to make sure to see if there's a plan in place at the schools for those asthmatics. They might have a standardized plan for all the asthmatics, or they might be individualized, especially someone who's more severe. And each child should have their own type of trigger that causes their asthma attack. When you do have a child come in, make sure that they understand how to use the inhaler. A lot of the times they don't use it correctly, and it's not going to help in an asthmatic attack if they don't know how to use the inhaler properly. So on the previous slide, for some reason, Screencastic is not allowing me to go back there. We want to know what are some of the triggers. So allergens include trees, shrubs, weeds, grasses, molds, pollen, spores, dust mites, animal dander, and cockroaches, people with food sensitivities, allergies, nuts, milk, etc. So those are some of the allergens that might precipitate an attack. Irritants such as cigarette smoke, wood smoke, odors and sprays also can precipitate an asthma attack. Exercise or exercise-induced asthma, that's someone who has an exacerbation related to physical exercise or exposure to cold air or changes in weather and temperature. Emotional stressors is also a factor. And you'll see people who have panic attacks. It can trigger a asthma attack. Those with endocrine factors such as puberty, menses, and thyroid. However, 20 to 40% of children with asthma may have no triggers. And like I said, exercise can trigger asthma. And prevention typically of exercise-induced asthma would be to administer a rescue inhaler, believe it or not, albuterol, prior to the active sports. And I know that a few of my sons had mild asthma, but they would have exercise-induced, and we would administer his albuterol prior to that, and he would perform much better. One of the best exercises to do that is not related to causing an exacerbation is swimming. So that's a good form of exercise to help prevent an asthma attack, but also to keep the child active. So a lot of times we encourage parents to give them swim lessons or to have them swim to keep them active and not to precipitate a asthma attack. So now on this slide, there are asthma expert panels, and this is a report 3. And this particular report comes from the National Asthma Education and Prevention Program. And basically what they have is they want to establish a diagnosis. So we want to know that this child actually has asthma. We want to assess the severity. They will use the step table to initiate therapy, which you saw in the previous slides. They'll educate about goals. What are our goals? Obviously get them in functioning with the least amount of asthma attacks that they can possibly have. Control the environment and have an action plan in place if an attack does occur. Okay, some of the medications that are used for asthmatics, they might use glucocorticosteroids. Those are on the basis of asthma treatment. They're currently considered the cornerstone of asthma management. They will use metered-dosed inhalers or nebulizers to administer it. So that's what you'll see. And they'll oftentimes use a spacer, and probably all of you are familiar with the spacer when you are administering an inhaler to a child in particular. But it helps to keep control and keep the medication with accurately and precisely into their lungs. Other ones they'll use is leukotriene modifiers. An example of that would be Singulair. They also will use immunomodulators. An example of that is Xolair. They use beta-adrenergic agonists, and that one you see quite a bit. They have LABA, which are long-acting beta-adrenergic agonists, and SABA, which are short-acting beta agonists. And an example of a short-acting one would be albuterol. That is also a rescue inhaler. So that helps to open up the airways and makes their breathing easier. They will also they have used in the past methylxanthines, and they do still sometimes use them, but they're no longer widely used. An example of that would be theophylline. And theophylline they used to give, especially when they had asthma attacks or they were in the hospitals, they would give them theophylline through IV. And you measure whether it's therapeutic and if it's at a toxic level. That's where we'll have measurements. They also had theophylline that they would give PO, but we don't see it as much anymore, them giving those. So there are new guidelines out, and these are age-related. So 0 to 4 is the first group, 5 to 11 is the second, 12 through adulthood is the third. So the focus is on long-term control meds. Example would be steroids such as Flonase, or long-acting beta agonist, LABA. So when you see LABA, you know that that's what that stands for. LABA, which is long-acting agonists. Those examples would be Ceravent, or a combo medication, which contains both a steroid and a LABA. Those would be Advair or immunomodulators. So the second class of meds is for short-term control and short-acting beta agonist, which is actually, we see quite a bit, and those are the SABA or albuterol. So those are some that you might see the children are getting. So what is some non-pharmacological control for asthma? We want to control the irritants. What is it that causes an exacerbation, and how can we prevent it? So we control the irritants. We don't expose them to milk if that causes an asthma attack. If they have an asthma attack because it's related to dog dander, we don't have a dog, or we don't have a cat, we don't have rugs because the dust causes an irritant, things like that. We also pre-treat exercise-induced asthma, like I mentioned about my son. When he played basketball in particular, he was great. He was a very, very good player, but we saw him decreasing in his ability to run, and he was diagnosed with asthma, so we were able to pre-treat him with the albuterol, which made him perform much better, and because he could breathe. Manage comorbidities, so if they have other illnesses along with it, we want to manage those and have a plan if there is an exacerbation and they do have an attack. So some of the nursing diagnoses in an exacerbation in particular: airway clearance ineffective, activity intolerance, breathing pattern ineffective, gas exchange impaired, family process impaired, and knowledge deficit. So those are all the areas that you can see are a problem that you can work on. So what are we going to do? We're going to educate regarding daily management and how to handle acute attacks. It has to be a partnership between the patient and the caregiver. So if it's not the patient, the parent. And as you'll see in the schools, you will see some children who have more controlled asthma than some who don't. And you can see on those who oftentimes who have really poorly managed asthma, there's not really a partnership between the caregiver or you as the nurse and the parent or the patient. And so it's very much encouraged to get a trusting relationship and to find a plan of care that helps to decrease exacerbations or asthma attacks. Also, lack of adherence to this prescribed regimen. That is another big factor. If the person does not stick to their plan of care, then you're going to see more occurrences of uncontrolled asthma, which then in turn oftentimes leads to emergency room visits and hospitalizations. Oops, can I go back? Yeah. Parental adherence to asthma treatment. Definitely you have to make sure that the parents, especially in younger age children, are following the medical recommendations, and sometimes they have different beliefs and concerns that they don't want to use, so we need to educate them on the medications and why they're important, or also on the different triggers that they should try to avoid. We do see inner city families more non-compliant to therapy. A lot of times it's associated with inaccurate perceptions of asthma or their ability to visit clinics and things like that. So for children, effective coping asthma is related to positive functioning in the family. So a lot of the times these children have issues in regards to friends and socialization related to their asthma, especially if it's severe. So they need a lot of social support and education on how to prevent and control asthma. Collaboration with nurses. So you as a school nurse have an important job. You want to be collaborating with the parents and with the physician's office to make sure that you have a plan in place and to help reduce missed school days or work days for the parents. Helping out to see if there's a way that they can get medications refilled and also to decrease emergency visits. So education must include the treatment regimen, plans for exacerbations, and evaluations for barriers. So, there is a condition called status asthmaticus. This is a medical emergency, and this is defined as an asthma that persists despite rigorous therapeutic measures. And this can occur even in someone who might be well managed normally. They might end up having an asthma attack and going into what's called status asthmaticus. So again, this is a medical emergency because we're not able to somehow alleviate this attack. So we would be calling 911 if you run into this particular problem. We try to treat initially with the beta-2 agonist, albuterol, along with any corticosteroids. Epinephrine may be added if relief is not achieved. Eventually what we see with someone in status asthmaticus is dehydration. They will be in respiratory acidosis, they'll suffer from hypoxia, and they'll have electrolyte imbalance, and all of those need to be treated, and they will need to be in the hospital for that, or have emergency called so that these things can be administered. Cystic fibrosis. Cystic fibrosis is actually a chronic condition, a genetic chronic condition, and it occurs primarily in white children. Gender is not a factor. So it occurs equally within males as it does in females. CF affects 1 in about 3,900 births each year, and both parents are carriers. So that means that they have a 25% chance, if both parents are carriers, of having a child with CF, or a 1 in 4 chance with each pregnancy. It's ultimately a fatal disease. The life expectancy is now about 37 years. It used to be into the teens. So we've actually prolonged lives. And we have seen people live even longer, some living even into their 60s. But for the most, on average, it's about 37 years. 40% of people with CF in the U.S. are 18 years or older. So we are seeing them, their lives being lengthened. What we do with the focused assessment of interest in pathophysiology, what happens with cystic fibrosis, is that this disease affects the exocrine glands. So it causes increased viscosity of mucus, marked increase in sweat chlorides, an increase in organic and enzymatic constituents of saliva, abnormalities of the autonomic nervous system, altered pancreatic function, and obstructed bronchi. So what happens in this, with the pancreas in particular, the pancreatic enzymes that we normally, people who do not have cystic fibrosis, are able to reach the small intestines and are part of digestion. However, with someone with CF, the pancreatic enzymes cannot reach the small intestines, and it's usually due to a blockage in the sphincter of Oddi. And as a result, the fat-soluble vitamins in a person with CF cannot be absorbed. So that's something that what we'll end up doing, and you'll learn in a couple of slides from now, is we actually have to supplement with pancreatic enzymes when these people who have CF eat, in order for them to properly digest fat and digest fat-soluble vitamins and things like that. Also, what's of interest is that the cervical mucus in females is increased, and the vas deferens in males may be blocked. Now, although both the sodium and chloride are affected, the defect appears to be primarily a result of abnormal chloride movement. So instead of free-flowing mucus secretions, the secretions become thickened. Okay, so here's like a pathophysiology chart that you can see. So there you have the basic defect. It affects the exocrine gland. And then what happens is abnormal mucus secretion and obstructions occur. So it will occur in the bronchi. So we get bronchial obstruction, chronic bronchial pneumonia they seem to get, and general obstructive pneumonia. They also have a abnormality in regards to their digestion. And oftentimes we'll see the first sign that someone might have cystic fibrosis is they have absence of meconium or insippated meconium. Meconium is the first bowel movement that a child has or a newborn has, and that it's black and tarry in consistency, and that's what they call it, meconium. So what that leads to is an intestinal obstruction of the newborn. This also affects the pancreatic ducts, which are secondary to degeneration of the pancreas. And we have pancreatic achelia and malabsorption syndrome. So you don't see them absorb. You typically see CF patients very thin and obviously have clubbing of their fingers and things like that, which we'll talk to in a little bit. It also affects the bile ducts, so they'll have focal biliary fibrosis with concretions and biliocirrhosis, and then eventually portal hypertension. So there's a lot that goes on. The clinical manifestations may include the intestinal obstruction in infancy, so absence of meconium, passing of meconium. Early respiratory findings, they'll see coughing, wheezing, or repeated infections. Sometimes they're not diagnosed right away, but they keep getting respiratory infections. Failure to thrive, a salty taste that oftentimes they will say, my child, when I kiss them, they taste salty. And infertility is something that is more prevalent in someone with CF because of the increase in mucosal, cervical mucus, and blockage in the vas deferens for the males. Diagnoses. They'll do a sweat chloride test, which is basically, they use a pilocarpine is applied to the skin, and then the sweat is analyzed for chloride. A normal chloride level is less than 40 milliequivalents per liter, and someone with CF would have a chloride level of greater than 60 milliequivalents in order for them to be diagnosed. They also will do a chest x-ray, which will reveal characteristic patchy atelectasis and obstructive emphysema. They will do pulmonary function tests, or PFTs, which indicate abnormal lung capacity and functions, and they'll do a stool analysis. And the stool analysis typically will find increased fat and enzymes, and oftentimes they will say someone with cystic fibrosis has very foul-smelling stools because of the presence of fat within the stool. So how do we manage? Management in the last 2 decades has improved the survival of children in CF, and this is largely due to antibiotic therapy and improved nutrition. The goals of treatment are to minimize pulmonary complications, ensure adequate nutrition, and assist the child and family in adapting in the health-related needs. So, therapeutic management. We will give medication. Those include bronchodilators to open up airways. They also will use recombinant human deoxyribonuclease, or rhDNase, and Dornase, alpha pulmonase, to decrease the viscosity of secretions. And they will give antibiotics to treat infections and also for tune-ups. They will do chest physiotherapy and O2 during acute episodes. O2 is during the acute episodes, but chest physiotherapy they might do on a routine basis, and that is to help loosen up secretions. They also will have different vests and things like that you can utilize in place of doing the actual chest physiotherapy. And I don't know if any of you have witnessed respiratory therapy doing chest physiotherapy on a person, regardless of whether they had CF or not, but sometimes they'll do that, and that helps to loosen up the secretions. And typically when they do that, they will medicate the person with inhaler prior to doing the chest physiotherapy, and that just helps loosen up everything. So usually they'll use an aerosol bronchodilator prior to administering chest physiotherapy. Other medications include pancreatic enzymes. And pancreatic enzymes, like I said, they oftentimes a person with CF does not or is not able to get the particular pancreatic enzymes to the small intestines to help with fat absorption and also fat-soluble vitamins. So they will use pancreatic enzymes. They usually come in like a pill form. However, you can sprinkle pancreatic enzymes, open up the pills and sprinkle them on the food so that the children can eat them because sometimes they can't swallow, and that is perfectly okay. They also will use water-soluble versions of vitamin A, D, E, and K. They want a diet that's high in protein and calories because, like I said, they are often very thin and they need high calories to get their proper nutritional requirements. Supplemental sodium may be needed, even though they taste salty. Remember, it's a defect more in the chloride. Okay. Some nursing diagnoses that you'll see with someone with cystic fibrosis is ineffective airway clearance related to viscosity of secretions, ineffective breathing pattern related to viscosity of mucus and airway obstructions, risk for infection related to thick mucosa, and altered nutrition related to inability to absorb nutrients. You also will see altered growth and development related to inadequate digestion of nutrients, fear and anxiety of altered coping related to uncertain outcome effects of CF, and possible need for hospitalization. Remember, they're living a little bit longer, so they are living into their teens and young adulthood, and as part of that, the sexual development usually is fairly normal, but they will have altered sexual function related to the increase in cervical mucosa and obstruction of the vas deferens. And so there's a lot that you could do as the person progresses and ages with this particular condition. There's also altered family process related to situational crisis. What are some of your nursing interventions? Well, assessment of this patient must include medical history, lab findings, review of systems, and a comparison of this child to normal growth and development. So we have the growth and development in children, in newborns, and in children that are based on sex. So it will be based on if they were born female or born male, because there are differences in sizes and factor and weight and length and head circumferences and things like that. So it is specific to the sex of the child. So they will do comparisons to see what is the norms for that child and see if they're keeping up with the growth and development. The medical history should also explore the family function and resources and cultures, and they oftentimes will do genetic counseling for these people once they have a child, because the likelihood of them having another child with this condition is 1 in 4 or 25% chance. If they do happen to have two children within the same family who have cystic fibrosis, they will put them in separate rooms, have them 5 or 6 feet apart, and that is because they actually become sick with each other's opportunistic infections. So if you ever saw the movie 5 Feet Away, it was with Dylan Sprout or something like, I think that's his name, Dylan Sprouse or whatever his name is. But he was on Zack and Cody. He was a Disney actor, but anyways, he played a part of a person who had cystic fibrosis, and there was a young girl in there who also had cystic fibrosis, and they had to maintain 5 feet apart, and that's something that it's really 5 or 6 feet. 6 feet is typically what you see in documentation and evaluations and studies that make it where you will not be exposed to someone else's virus. If it's, that usually is the barrier, it's that 5 or 6 feet. So that's something important to remember in regards to when two cystic fibrosis patients are together. So nursing interventions, you want to assess for respiratory function as ordered, intervene based on data, like provide O2 chest PT or respiratory treatment, administer meds to manage deficit, assess nutritional status, monitor their stools, administer the enzymes, and teach self-care. And here are some other things you want to assess for knowledge deficit: support normal growth and development, prevent hazards, which might interfere with growth and development, assess coping and availability of resources. Here is the link to the CF Foundation, where we could refer them to, and also any other helping strategies as they advance in age. And that is it. If you have any questions or concerns, please feel free to email me at jlougrey@hcc.edu. Thanks.